The broadcast is now starting. All attendees are in listen-only mode.
Good morning, everyone. This is Deanna Mitchell with Leading Age Michigan, and I want to welcome you to our next Safe and Calm COVID-19 pandemic webinar. As you know, we're holding these weekly. It would seem that over time, I would think that we would have more clarification about things and that things would settle. But unfortunately, this week again, that's not the case. We have an awful lot of new directives. Some of them are kind of conflicting and confusing. So we'll try and get through that as best we can. I want to remind everyone what the purpose of our webinars are. Basically, it's to provide easy access to pertinent materials. We put those on our website almost every day. We also want to keep you updated and knowledgeable about what's going on at any given time, and also to get some feedback. I do want to remind everyone that there's a very large number of people signed on for today's webinar, and so if you do have a question, we have grouped questions again at the end of each discussion topic, but please use your chat to ask a question, and we will pause several times in the middle of the webinar and attempt to answer those. However, there are a lot of new things going on, so we might have to get back with you later about some of the questions as we get more information from the state. And we will be doing another Q&A document at the end of this session. So again, this is our standard forum agenda. I have not updated Leading Age Michigan Advocacy this week since our advocacy work is going to shift a bit since the blanket waivers came out on Monday evening. A lot of our advocacy asks have been granted, so we're kind of redoing our advocacy piece this week. So I like to start with kind of an overview of what's going on nationally and in Michigan. We can move forward to the next slide. I have changed the formats for our slide because I kind of ran out of room for each graph. So these numbers look really more dramatic, but mostly because they're going week to week. So as of yesterday, nationally, there were 163,000 cases. And still growing, unfortunately. This map I like because it's not overwhelming visually, and it identifies the number of cases in each state. So the larger the bubble in each state, the larger the number of cases. Just because the bubble over Michigan is kind of toward the upper part of the lower peninsula does not mean that that's where the cases are. That is just, it just identifies the number of cases in Michigan overall. We all know that the predominant number are in Southeast Michigan. One of the things that's a little concerning is that Michigan and its surrounding states pretty much had the same number of cases in early March. And yet Michigan and Illinois cases have grown faster than the other surrounding states. So that's kind of a thing that, you know, I think the administration needs to look at as we move forward. This is a graphic that I first introduced last week, and I think it's very telling. It talks about the amount of time it takes for the deaths to double. So on the left side of the slide, it shows you countries where the deaths double from every day all the way down to every month. And you'll see that China, Iran, and South Korea are leveling off. The United States, still not there yet. It looks like we're about to peak. It looks like Italy may begin to be leveling off, but we are still we've not crested yet. Let's just put it that way. One of the things that I did look at was the top 10 states in terms of total cases. And you'll note that Michigan is number 4. New York, of course, far exceeds any other state. But also the percent of total cases who died. Michigan's percent of that is 2.8. Washington was 4.2. Louisiana is up to 4.6. I think a lot of that, however, anything above 2.0 seems to be in areas where there are very, very high amount of urban people affected. So I think it's the fact that there are a lot of people in Detroit who are at high risk in terms of comorbidities who have been affected by this. And of course, we know that Washington had a lot of cases in nursing homes before they even knew that they were COVID positive. Here in Michigan, here's the slide for Michigan. As of yesterday morning, we had 7,615 cases. And again, I'm doing this week by week, so you'll see a different curve happening. We will continue to monitor this week by week, and hopefully we can see it cresting soon. This is the time it takes for deaths to double for Michigan. And you'll note that Michigan is still rising again. So all those other states are not identified there. There are some obviously that have leveled off somewhat, but Michigan is still rising. So that's kind of our national and state outbreak update. We're going to move on to resource updates, and I'm going to start with the large number of waivers that came out. If you remember, we talked about blanket waivers. Remembering that blanket waivers pretty much have come from the feds, and they apply to every intended entity. In other words, you don't have to meet a certain criteria if you're a nursing home to be covered by nursing home waivers. And by 3/29, there were only 2 blanket waivers for nursing homes. One was the waiver of the 3-day stay, which we've talked about, and also the waiver for time frame requirements for the MDS. So those still exist, and then actually they were repeated in the blanket waiver update that came out late Monday. So the additional blanket waivers, there was a huge document that came out Monday evening from CMS that identified a large number of blanket waivers. And there are a lot of things in here that are very, very positive for skilled nursing facility and skilled nursing facilities as they relate to work with hospitals and other entities. So these are some of the providers who are affected by the blanket waivers. I have put a lot of the information in the slides about providers that perhaps do not directly impact SNFs, so I'm not going to go through those, but I did include them on the slide so that you could have a sense of what the waivers were like for some of these other entities. So starting with hospitals, none of these really apply on this slide to skilled nursing homes or other licensed entities much. The waiver does allow hospitals to screen patients at a location offsite. And that's, of course, very important that patients not come into the hospital to be screened for COVID. Verbal orders, patient rights. The patient rights that they waive for hospitals are really kind of, I don't know, inconsequential. It has to do with timing to provide a medical record, policies and procedures on visitation, things like that. Reuse of masks, and how that would happen in a hospital. This next one, though, is very pertinent to skilled nursing facilities. So the hospitals do not have to provide the normal, routine, detailed information for discharge planning to patients so that they don't necessarily have to provide that quality information for whatever post-acute care provider they may be referring a patient to. In other words, currently for home health agencies and SNFs, they have to talk about individual star ratings, how your performance is compared to other performance. They're supposed to provide that to residents as they do their discharge decisions. They no longer have to do that during this emergency. They still are required, however, to ensure the patient is discharged to an appropriate setting. So the hospital is required to make sure that it is a safe discharge. They must move to post-acute care with all of the necessary information for that provider to take care of the patient. So they still have to make sure that you know what you need to know about the patient in order to take care of them. They no longer have to provide a long list of post-acute care providers to the patient. And they don't necessarily have to provide information about the patient ability to choose. We all know that under Medicare, patients have the ability to choose whatever provider they want. They still have that ability, but the hospital doesn't have to provide information about it. And they don't have to, hospitals no longer have to identify that any home health agency or SNF that they're referring to is something that they have a relationship with or a financial interest in. So additionally, there's some physician privilege expiration date waivers as well. Medical records, information about advance directives, that's something hospitals no longer have to do. They don't have to provide information on admission about advance directives. They can identify different areas for patient care and quarantine. The rest of this is kind of routine for hospitals and not really directly related to post-acute care. One of the things that I thought was interesting is that nursing care plans are waived for hospitals. And I can guarantee you that nursing care plans are not waived for nursing homes at this point. The rest of this, I think, has to do with some basic stuff. There are some evaluation activities that they're required to do in terms of emergency preparedness, and oddly enough, they have been waived. And of course, they're waiving personnel requirements for respiratory services because they need some assistance there. Temporary expansion locations, they can operate any part of the hospital in any location during the emergency. They do have flexibility for their inpatient rehab rule. If you note that patients, 60% of their patients have to meet a certain ability to do rehab, that is being waived. So the blanket waiver has a specific section for skilled nursing and nursing homes. Again, as I said before, there's the same 3-day stay language, the same MDS language, but there's a long list of additional waivers. The first is that the PB&J reporting requirements are suspended for now. PASAR requirements are suspended, but only for 30 days. Most of these are suspended for the duration of the emergency, but the PASAR requirement specifically says for 30 days. So a non-SNF building can be temporarily certified available for use by the SNF in the event that you need to set up a cohort of patients who might need isolation or are all COVID-19 positive. It waives the conditions of participation and certification requirements for opening a nursing facility for that particular need if the state determines a need for it. However, state licensure rules would apply. There are a lot of state licensure rules that have been waived, but setting up a whole new nursing home would be something that you would have to at least talk to the LARA about, because you would have to apply for an emergency CON at this point. Last on this page, the blanket waiver allows for rooms not normally used as a room to be used to accommodate beds, activity rooms, meeting rooms, dining rooms, etc. So it doesn't say here that the rooms have to be equipped in a certain way. The department guidance earlier said that you could use additional rooms for surge capacity, but it identified that you really have to, meet the requirements for patient care in the room. This does not say that, so there might be some state requirements that differ from this. Obviously, allows the facility to restrict in-person meetings and limit gatherings. We've pretty much already done that. This is the important one. Finally, they have waived aspects of training and certification of nurse aides. So it waives the rule that SNFs or nursing facilities cannot employ anyone longer than 4 months unless they meet the training and certification requirements. So this finally looks like you can use staff who are not certified to do direct patient care. However, you have to have documentation and ensure that the individual is competent in whatever tasks are assigned to them. These people will be working under the delegation authority of an RN. So you have to have an RN oversee them and supervise them and ensure that they have documented competency and skills for whatever pieces are assigned to them. So you could train, a group to make beds, do baths, whatever it might be. Of course, bed making is not certified, but whatever that piece might be, they don't have to be competent in everything, but they have to be competent in the areas that you're assigning to them. They have waived in-person visits for physicians and proposed using telehealth options instead. This is another important one because when we had a conference call really with LARA on Monday, they were pushing back really hard on the fact that you couldn't move patients against their will in order to cohort for the safety of the entire building. However, this blanket waiver from CMS says that the requirement for resident choice in roommates or rooms has been waived, and they can't refuse to transfer to another room in the facility if it's in the facility's best interest. They believe that this will foster preferable placements and more safe placements for COVID-19 patients. So this is an important piece as we see this spread move throughout Michigan. For skilled nursing, again, allows some exceptions to for transfers and discharges to another facility solely for cohorting. So you can transfer residents with suspected or confirmed cases to a place dedicated for such patients, or you can transfer patients to non-COVID facilities if you are a center of care for the virus, or you can transfer to other facilities for observation for patients with respiratory infections. So depending on what's happening in your local community, if you have some facilities that have defined themselves as appropriate to take care of COVID patients, you can transfer these patients solely for cohorting purposes. The receiving facility has to accept the patient verbally or in writing, and you must document the date, time, and person that the receiving facility communicated agreement. So they're waiving really the advance notification of options that you normally have to provide to a resident before transfer. And they're also waiving that the written notice be provided before discharge, but the notice is still required and has to be given as soon as possible. Another waiver is for the time frames for certain care planning requirements for residents who are discharged as noted for transfer. In other words, you don't necessarily have to have your care plans completed for these patients that you're transferring. Receiving facilities should complete those care plans as soon as possible. So there's also the scenario where some facilities might transfer patients to an alternate site, but still provide care for that patient once they get there. And this occurs and is probably written in most people's emergency preparedness plan. There is a scenario where you simply need to house someone in a different building, but you'll still be providing services. If that's the case, providers who are doing the care should continue to bill Medicare normally for each day of care. The transferring facility is then responsible to reimburse the other provider if that should be the case. If the transferring facility, the facility that the patient's being sent from, does not intend to provide services, the receiving entity is responsible for Medicare billing and should follow the Medicare claims processing manual for that. There's a lot of details about that, so I would refer you to both the waiver document and the manual. Facilities are responsible to ensure that any transfers in and out of the facility are conducted in a safe and orderly manner, obviously. And states are reminded at the end of this section that the state does have the authority to transfer Medicare and Medicaid patients themselves to another facility if they decide that there are certain facilities that are better to house some of these patients. Home health agencies. There's really very little here that would impact nursing homes. Requests for anticipated payments, extends the auto cancellation. In other words, it moves it, it postpones it. Extends the 5-day completion requirement for the comprehensive assessment, waives the 30-day OASIS submission deadline. Initial assessments and determination of homebound status can be done remotely or by record review. That potentially could impact nursing homes if you're referring to a home health agency. I would think about allowing the home health agency to really coordinate with you what this patient might need and what their COVID status is well before they move to the community. And waives on-site visits for home health aide supervision. Hospice waives the requirement to use volunteers for patient care hours. Most hospices have a certain percentage of time they have to use volunteers. Waives the timeline for their assessments, for aide supervision, and to provide certain therapies. Dialysis issues. So this was a bit of a surprise to me, and maybe it's because I'm not really well versed in dialysis and nursing homes, but the waiver allows that dialysis facilities can provide services directly on its main premises and can provide services in a nursing home or skilled nursing facility. And these services must be under the direction of that facility, that dialysis program itself. and must furnish all dialysis care and services equipment. And part of this is really because some dialysis facilities would be very problematic in terms of spread and contagion. So it's important in some instances where they might be able to provide dialysis services in your building. However, that could provoke a whole lot of other issues, and so that will have to come up with each case. The dialysis center will be billing Medicare, and there's certain coding requirements and billing discussion about that. So if this comes up, I would refer you to the waiver document as well. Durable medical equipment. The Medicare administrative contractors, the MACs, can waive replacements if equipment, supplies are lost, or you have to replace something earlier than you might have thought. Normally there's a face-to-face requirement to determine the need, a new physician order, new medical necessity documentation. Those are not required at this point. That's all been waived. However, the company still has to document on the claim why the replacement was necessary. So a few other pieces, and some of these don't feel new to us. Some of them have come through in our executive orders. Out-of-state providers can waive licensing for anything that they're licensed in another state, as long as they're not excluded from practice. State or local licensure requirements may still apply. And again, these have been waived by Michigan in an executive order. Providers can apply for Medicare temporary billing privileges, and Medicare appeals extensions will be allowed. However, there's a lot of detail about that that's a little bit overwhelming for a webinar, and so I ask everyone to check the narrative for further information there. So additionally, prior authorization for Medicaid fee-for-service programs have been waived. I don't think that really impacts nursing homes or home health agencies very much. It impacts mostly hospitalization. Again, out-of-state provider enrollment, revalidation requirements, and there's a discussion of the Stark's physician self-referral law there as well. Again, that's a very complex discussion. So if that's an issue for you, which I actually doubt, see the narrative. So that's pretty much a summary of the blanket waivers. We're going to pause here for questions about these new blanket waivers. So we'll give it a second.
All right, I do have a few questions that came in. Before I do get to the questions, I do have something that I have to say really fast. We just got news from Larry Horvath to DEH. Basically, fingerprinting has been suspended for hospitals and nursing homes. Only certain parts of the hospitals will be required to fingerprint. With that said, the employer should perform an online iChat and enter the employee in the background check system to allow us to track after the emergency order expires. We also encourage providers that plan to keep these temporary employees after the emergency order to still proceed with fingerprinting when possible. Many of the fingerprinting offices are still open. So just wanted to let everyone know that, as we just got that information in very recently. So basically, the very first question was, can you confirm the idea that fingerprinting and background checks are or are not required right now to hire new employees? What about physical and drug screens? I think part of that was just answered with that announcement about the fingerprinting. I'm not sure about the physical or drug screens. Maybe Deanna could go further on that.
We've not received any information about waiving of physicals or drug screens. I think that at one point maybe the narrative said that you could do, and this might be for HFAs and AFCs. I'll have to think about that as we get to that part, because they sent out a Q&A earlier this week. I think that there's a suggestion that if you can't get into the physician office, that the facility do a basic health screen, allow the employee to work, and ensure that they have a real physical as soon as possible. Drug screens, to my knowledge, have not been addressed, but I am happy to hear that we finally have some definitive answers about fingerprinting. I'm going to answer this question and issue now, but there's a slide later that when we get to some of the directives from LARA about this as well, and I'll repeat it then because it has been so very confusing. So at this point, what it looks like is that the executive order 2020-30 says that health professionals, licensed people, are waived from getting fingerprinting. And they're only talking about fingerprinting, not background checks, but fingerprinting. If the department determines that it's unavailable. And the last thing that I heard from the department is that it is not unavailable. And so those persons technically, unless we hear something else, are not waived from getting fingerprinting. Additionally, HFAs and AFCs are not waived from fingerprinting. However, the executive order that includes nursing homes and hospitals, and Blake said parts of hospitals, and we'll have to look at that language a little bit closer, have been determined to be waived from fingerprinting, which is something that we were getting mixed messages from LARA about because they kept talking about whether or not that state executive order conflicts with federal guidelines. But it's good to know that we heard from Larry this morning that nursing home fingerprinting is not required at this point. However, it does, at least for now, appear to be allowed or required actually for homes for the aged, AFCs, and healthcare professionals. I don't know if that will stand. We'll have to have some further communications to get clarity about those pieces, but nursing homes is waived. So any other questions, Blake, for this portion?
Yes. Does this mean that the cost of meals for hospital staff will be recoverable? And then it said CMS also is issuing a blanket waiver to allow hospitals to provide benefits and support to their medical staffs, such as multiple daily meals, laundry service for personal clothing, or child care services, while the physicians and other staff are at the hospital and engaging in activities that benefit the hospital and its patients.
Wow, I have to be perfectly honest here. That is out of my knowledge and expertise. However, if you, since you've submitted that question, we will definitely look into that.
All right. Where can we get a list for our county of places that are specializing? Has anyone received one?
I'm not aware that there's a list somewhere. I do know that through a lot of our conference calls and conversations with other providers and the department, that there are some facilities that are suggesting that they are setting up specific wings and are planning to take the COVID patients. I think it'd be good for us to have a list. However, at this point, we don't. What I have been suggesting to people over time is that they work with their local health department and their referring hospital and discuss how the COVID patients are moving through their individual communities. I think that working with your hospital referring sources, especially your primary one, is like critical so that you can expedite and streamline the process to move those patients out as safely, but also as soon as possible. If we get more information about any listing, we can certainly post it. But again, I encourage you to work in your local community and figure out what that local community plan would be.
All right. Is bed hold agreement still required?
Bed hold agreement. There was some momentary discussion of bed holds during our conference call with Larry Horvath on Monday. I do not, to be honest, remember the pieces of that. So since you've submitted that question again, we will confirm it and get back.
Can the state decide that a person can go to a different facility, and can the state force the receiving facility to take that person?
My understanding is that yes, the state can, but it has not, and I'm not sure whether they will. We all know that in New York they have done that. I think we are trying to avoid that here, and so far they have not, but they certainly have it in their power to do so under the emergency acts.
All right. This is more of a statement, but CMS said yesterday on the call that they are not waiving the time requirements for training CNAs. And then another question, basically the breaking news comment, does this apply to HFA or AFCs, yes or no? I'm not sure if you would know that yet, Deanna, or not, since we did just find that out. It might have to be something that we look into a little bit further.
Right, so let's go back to the first statement. CMS is not waiving the training time, but it seems in the blanket that they have waived the training. So we'll have to get back and think about what that means. The blanket waiver was sent out Monday afternoon, so I would think that yesterday CMS would have understood that. So I guess we'll have to look into that a little bit further. It doesn't make sense to me. The other issue is if we were talking about fingerprinting for HFAs and AFCs, remembering that everything is so fluid that as I'm on this webinar, something could change. But as of this morning, there was a Q&A document sent out yesterday that said that AFCs and HFAs were not waived from fingerprinting.
All right, and then the last question that I see so far right now, does the waiver only apply to traditional Med A patients, or does it also cover managed care?
It would, anything that, yes, it would cover managed care patients as well.
All right, well, I believe that is all the questions we have for now, so we can go ahead and move forward if you'd like, Deanna.
Yes, let's move forward. So the Governor's Executive Order 2020-30, we're going to review that fairly quickly. Basically, it waives scope of practice laws. I'm not going to go through all of the pieces here, but they are, again, listed here for your information. Basically, medical services can be provided by advanced practice professionals without supervision. The Michigan Medical Society did not like this, but it has been waived for now. RNs and LPNs can order collection of specimens for COVID on their own, and LPNs can act within their scope of practice without RN supervision. As we all know that LPNs are often have delegated duties under the supervision of an RN, and right now that RN supervision is waived. The EO, the executive order, allows students in certain professional programs to volunteer work in a facility appropriate to their education and in consultation with medical leadership. So the same thing applies here as in the blanket waiver. If you assign someone to a certain task, you have to make sure that they are all competent in that task and have documentation that supports that. The order also allows certain persons to be respiratory therapy extenders. Some of these others are kind of routine things that we keep hearing about. One of the things that I think is kind of important here And I would like to have a little bit more understanding of this, because we have talked about liability issues during this emergency quite a bit. We're worried about facility risk as we are working under not wonderful circumstances. But the actual language says that licensed health professionals or designated healthcare facilities are not liable for injury sustained by a person by reason of providing medical services in support of the emergency response. So that's some limited liability discussion, but we are worried about overall liability as well. License renewals are suspended. Here are the fingerprinting rules. Healthcare professionals canceled if LARA judges that service to be unavailable. LARA has not done that. Continuing ed and recertification requirements are suspended. The other fingerprinting piece is any law or regulation is temporarily suspended that requires fingerprinting for all of those provider entities, including nursing homes. And we've just heard that that does apply to nursing homes, so that's good. And all of these pieces are effective through the end of the declared emergency. So, any additional questions about the governor's executive order?
Right now, I do not see any questions that have come through, but I will wait a second just to see if anybody is typing basically right now.
Okay, great.
While we are waiting, just wanted to let you know that some of this stuff will be covered in the upcoming events that we do have going on. We have our SNF Regulatory Day, which will be kind of like our Finance and Strategy Day setup, if anyone has been in that so far. So our SNF Regulatory Day will be a virtual training live webinar on Thursday, April 9th, so you can go ahead and sign up for that if you'd like. I'm trying to see another course that we have coming up. I believe our ICD-10 and PDPM course will also be coming up, and that will be in a few weeks, Tuesday, April 21st. So feel free to sign up for those on leadingagemi.org. All right, I did just have one question come in. What do we need to do for planning on doing some of the things that were waived at the end of the emergency?
I'm sorry, could you restate that, please?
Yep. What do we need to do for planning? What do we need to do for undoing some of the planning or some of the things that were waived at the end of the emergency?
Oh, you know, that's a very good question, and it's really unclear. One of the pieces is that facilities have the ability to expand their beds if they get an emergency CON. And these emergency CONs will only last during the duration of the emergency. Well, what if you have patients in those beds? I don't think there's been a lot of clarity about that, and I think that that's something that we'll have to talk to the department about. I don't think actually that the department's focused on that right now. What they're mostly concerned about is getting through the emergency. But we can bring that up because those transition back periods, you know, I would hope that we would get some leeway to move back to normal once the COVID crisis is immediately over. But I haven't heard any directives about how any of that would work.
She followed up with a question, said, could we ask for bridge transition language?
I think that would be great. And I think that that's something that maybe we can think about in our advocacy document that we're currently updating.
All right, I do not see any other questions so far, so are you ready? Oh, never. Looks like Leading Age Michigan is also planning a topical complimentary Safe and Calm webinar services. Series, excuse me, sorry about that. Complimentary Safe and Calm webinar series, and I believe that will be, we have one this afternoon at 2 p.m. So if you are interested in that, feel free to pretty much reach out from anyone at Leading Age, and we will make sure that we get you registered for that. We do have another question. Did you say that the 3-day waiver also includes all managed care plans as well?
Yes. Yes. The 3-day waiver applies to any Medicare patient.
All right. Well, I think that is it for questions, so we will go ahead and move on for now.
Okay, this is the Q&A document that we received, I think, yesterday morning from the Department of Licensing and Regulatory Affairs. I'll be honest with you, I was challenged a bit by this document because there's nothing written at the top of it that identifies the program. The only thing that says that this is appropriate for AFCs and HFAs is its electronic title. So if you don't have the electronic title in front of you, there's nothing at the top of this. AFCs are discussed during it, but there's an awful lot of pieces that don't. So it took me a while to figure some of this out. So as of yesterday, AFCs and HFAs must have the proper supplies and staff to meet the needs of the resident when discharged. This is not different than the requirement that nursing homes have the ability to take care of the patient if those residents have COVID-19 and they're being discharged from the hospital. The documents suggest that you look at these additional pieces, whether or not the patient is appropriate for discontinuing transmission-based precautions, and there is a CDC interim guidance for that. You can find it right on their website. They believe that in order to be transferred back, the patient should have gone 3 days without fever and had some improvement in symptoms if they're COVID positive, to ensure that you have the PPE or medical expertise as needed to meet the resident needs, and that discharging hospitals should be able to provide you a detailed summary of what the resident care needs before you consider taking them. Additional pieces, facilities can start staff prior to TB tests, but should screen in the interim for tuberculosis, and of course get the TB tests as soon as possible. Again, fingerprinting is not waived, and facilities can offer conditional employment as long as new employees are fingerprinted within 10 days. And that's pretty much almost verbatim. AFC licensing will accept a 60-day extension on recertifications for CPR and first aid, so those can be a little late if needed. New staff, first aid and CPR can be completed by using online training until the crisis is over. But again, they must have in-person training as soon as possible later. At any rate, facilities must ensure that new staff are competent before being left alone in the facility. So however you train these persons in the interim, they have to be tested and demonstrate that they're competent, especially before being left alone as staff in a facility. That makes good sense. References for new hires, education verification, those time frames for new employees have been extended, but again, they suggest that facilities do not allow new staff to work alone until the information has been obtained. Facilities can postpone full fire drills if residents cannot follow social distancing, but the facility staff can run a drill for themselves if necessary to meet the requirement. And during this emergency, that AFC and HFA licensing staff are considered essential staff, so they're all working. The Bureau of Fire Services has postponed all non-essential inspections and will only conduct those that are of serious nature. However, facilities are expected to address any issues with their fire panel or their overall system immediately. There is an expectation also that vendor testing of sprinklers and alarms may be delayed. But again, then facilities need to make sure that their systems are working. I have a repeat here. I'm sorry about essential staff. There's no ban on new admissions, but all should be screened for potential acute respiratory symptoms. Facilities conduct their own health assessment or telehealth visit for employees who can't get a pre-employment physical, but must get an in-person physical when available. I think we talked about that a little bit earlier. This is an important one. Facilities should assist in resident communication with the family if the resident does not have a phone or a computer. And that goes for nursing homes as well. We'll talk about that a little bit more. Hospice visitors are allowed, but again, they should be screened just like anyone else for any acute respiratory symptoms. The department advises that residents should not really leave the facility, but there is no ban on leaving the facility. And so on a case-by-case basis, facilities should identify whether or not these persons are able to apply social distancing. If you know that they're not social distancing, or you know that they're not following some safe protocols, the facility does have the ability to issue a discharge notice in alignment with the current rules for that. I would definitely talk to LARA before that occurs, but you do have the right to protect the patients that are currently in your facility for someone who is moving out and about in the community and is taking on some risk. So this was my fingerprinting discussion that we already had. So again, we have two pieces of the executive order. And so I'm going to repeat this one more time because this has been a painful topic for the last 2 days. We've gotten, I don't know, probably 10, 15 emails about it. Fingerprinting for any healthcare professional is canceled, but only if LARA judges that service to be unavailable, and they have not. And then the last one from the Q&A document, fingerprinting is not waived for AFCs and HFAs, but facilities can offer conditional employment as long as employees are fingerprinted within 10 days. And then last but not least, fingerprinting for nursing homes and other entities listed here has been suspended. Any questions about these pieces?
Right now, I do not have any questions that came through. Do you want to wait a second, or do you just want to keep going through?
We'll wait a second.
All right.
Okay, I guess we'll move forward.
All right.
So a few other updates. You can move the slide forward. Monday was a really kind of strange day for us. We had a conference call in the morning with some of the LARA staff. And then we had a conference call with Larry Horvath at the end of the day. And there was really, I don't know that the content was necessarily different, but the focus was definitely different. So I'm starting with a summary here of the conference call that we held with Larry, because it felt that Larry gave a little bit more clear direction about some of the stuff that came through in the morning. There were additional things that were discussed in the morning call, and I'll talk about those later. So the Department of Health and Human Services, who are also on that call with Larry Horvath, was currently looking at stiff financial situations every 30 days. They do understand very clearly that a lot of skilled nursing facilities are really having cash flow issues. So they have authorized $15 million for advanced cash payments, and letters through file transfers should be coming soon if they haven't gone out already. These are only advanced payments. They're not additional payments. And all of that will have to be reconciled against your cost reports later. Providers have let them know that this is probably not going to be sufficient in order to cover the additional costs that all of us are feeling, all of you all are feeling, based on lowered census and higher costs. But this is what we have for now. Provider taxes that were due April 10th have been postponed until May. However, then both months, at least at this point, are due in May. Providers should try to quantify funding and resource needs for the department. So if you have information about some of the difficulty you're having in terms of funding resource, we know about PPE, that we can forward those messages onto the department, please feel free to email me. There was, I think, a good suggestion that CMPs could be used to support care in nursing homes. It certainly would be appropriate considering the rules for use of CMP funds and the fact that Michigan has difficulty finding an appropriate use for them. So I'm hoping that the department takes that to heart. So this is directly from Larry. The goal for the survey agency is to work through the CMS objectives to make sure that those objectives actually work for providers and the need to keep residents safe. So it kind of implied that there's a balance there. They have to make sure that they survey according to the CMS guidelines, but they also want to make sure that providers have the ability to keep these residents safe. As we all know, last week they started provider wellness checks. The department found that they were interrupting the facility's ability to serve their patients, and so these have been suspended. As we all know, routine surveys have been suspended. IJs and infection control surveys continue. Unlicensed staff can help out as long as the work, again, is delegated by a registered nurse and appropriate training and oversight exists. We've talked about that already. And Larry did say during this call that background checks were eliminated in the governor's recent order, but I believe at that time he was only talking about nursing homes. He suggests that people track their PPE shortages so he knows where to put some pressure to get more equipment. And one of the things that he suggested for these infection control surveys is that people need to focus on how they are gowning and degowning and using personal protective equipment appropriately, with a focus on hand washing as well. Those will be something that the surveyors will be looking at. So this is the piece that felt different from the morning to the afternoon. Does the nursing home have to take a COVID-19 patient back? And the same rules were discussed in both the morning and afternoon sessions, but the focus was different. The morning session really focused on the fact of resident rights, that the resident has a right to come back, but the normal rules apply. But the Horvath discussion was on the focus on the need to be able to serve that resident. So at this point, a facility does not have to take a COVID-19 admission at all if they feel that they cannot serve them. And they do not have to take a resident back into the facility if they can prove that they cannot serve them. However, there's much more pressure to take your residents back, and the resident rights issues still apply. But if you don't have the ability to care for them, you should not take them back. And this is something, again, that you should be discussing with your hospital planner and your hospital, your referring hospital, and your local health department and other facilities around you to identify if there are places where these patients are already being cohorted. That's something that you need to work out. But you absolutely must clearly document why you cannot serve this patient. And these are the same rules that have always been in effect. Can you expand beds? Yes. However, in order to expand your beds beyond your current license number, you need an emergency CON. And the department, actually Larry himself suggested that you only need to file for this emergency CON, and you don't even have to wait for the department response, as long as you are not moving outside your current licensed structural footprint. So you can't move outside of the boundaries of the facility that's currently under licensure. But the trick is that this expansion is only allowed during the emergency period. And as someone questioned before, it's unclear what that transition period might look like. There are other options to use non-available beds and place Medicaid patients in any facility bed at this point. However, there are a lot of details about that, especially about how it might affect cost reporting, and we're still waiting to hear about we're really still waiting for answers about that. So there could be some issues there. I know that some people are planning to expand into non-available beds in other areas. So additional information from the first call, and I'm sorry that this kind of broke up a little bit, but they talked about the nursing homes voluntarily using the hospital transfer form, and that transfer form is located at on an MDHHS website under what protocol should I use to treat a COVID-19 patient. And if you use this link, you'll find that there's a lot of resource materials about COVID-19 on that website. Hospitals are expected to work facilities to ensure that they have enough supplies before you have to take a COVID-19 admission, so they still have the responsibility to provide a safe discharge. So, you know, the onus is on them as well. Hospitals can work with a facility to attempt to find a better placement. Again, infection control facilities will continue to be a focus. Excuse me, I'm sorry. Resident choice was still the paramount issue over moves to provide isolation rooms, and that was finally addressed in the recent blanket waiver. So that's not currently an issue. And one of the things that keeps coming up in both conversations for AFCs, HFAs, and nursing homes is ensuring that you're providing alternative means of communication for residents. That's both CMS focus and a long-term care ombudsman focus in Michigan. So, any other questions?
Yes. Can members receive a copy of the waivers if they want?
We have posted the waiver documents, so they are available already. If you can't find them, shoot me an email and I'll help you.
All right. And then just a quick reminder, if you are signed up for our Finance and Strategy Day, a lot of this MDHHS policies will be specifically addressed by Phyllis Adams this afternoon at 12:30. I believe that you could probably still register for that if you'd like. You would not be able to receive CE credit for that, but if you were interested in listening in on that, I'm sure that you could do that as well. Just for clarification, are SNF facilities currently able to move Medicaid residents into rooms not currently licensed for Medicaid?
Okay, Dalton. I'm sorry, Blake. Let's move on.
Did you hear the question?
Oh, that was a question. I'm sorry. Say it again.
Just for clarification, are SNF facilities currently able to move Medicaid residents into rooms not currently licensed for Medicaid?
Yes, without a doubt.
Okay.
However, excuse me, Blake. It's not clear that you can move a Medicare patient though in a non-Medicare bed. That's a CMS directive that I have not seen yet, but you can move a Medicaid patient into any bed that you have open in your facility.
All right, I don't see any other questions, so we will go ahead and move on now.
Okay, so we did hear from Lourdes, one of our member communities yesterday, that they had an infection control survey, I believe over the weekend, and they were willing to discuss that experience with us this morning for a few minutes. So it might take us a couple minutes to open their mic, but we're going to work on that now.
All right, I do not see Cindy in here, but I do see Maureen McGee. Should I go ahead and unmute her?
Yes, please unmute Maureen.
All right, Maureen, just letting you know, I'm clicking to unmute you right now, so you are good and you can speak whenever.
Hi, this is Maureen, and I'm Judy Murray here, our Director of Nursing, and our survey was yesterday, Deanna.
And continuing on through today, but remotely.
Can you hear us?
Yes, we can hear you.
Okay. So they basically walked in and said that it was a COVID-19 survey, and they gave us the checklist of everything that they wanted, which is a lot like the survey for an annual, except it's a little more geared towards the self-assessment. So they then sent Judy an email, which I think would have been a little easier to do it a different way. Sent Judy an email at 9:30 asking for all of these policies.
They wanted remote electronic access too, and they kept stressing they wanted full access to our medical record. And, you know, could not give, I tried to get more specifics. What do you mean by full access? You pretty much have full access when you come in during the survey, but we did give them remote access, and we gave them the usual access we give surveyors, and didn't hear any feedback that it was, you know, they were looking for more. They wanted to see our infection prevention control program. They wanted to see our facility assessment that was sent out, I think, last week from the state.
The self-assessment.
The focus survey for nursing homes, that self-assessment. They wanted to see that. A lot of policies. They wanted to know our screening process, criteria and restriction criteria and protocols for entry into the building. They wanted environmental cleaning, what kind of brand of disinfectant we were using. They wanted to see staff education on the COVID-19, which, you know, things have been evolving so quickly. What we have resorted to is using memos and doing just at the nursing units and on the floors, just the group discussions, and then posting the memos throughout the building. They seem to accept that. They wanted to see what we were doing for screening of patients in the building. We have been monitoring temps. We have been monitoring new admissions more diligently than we were monitoring our long-term care residents. They wanted to see that those respiratory assessments were being done twice a day, along with the temperatures. They wanted to see guidance on returning to work for staff. They wanted to know if we had any active cases of employees or residents in the building. It was a lot of policies too, which, you know, none of us at this point really have time with a situation that's just been evolving over the last couple of weeks. Yeah, they wanted our emergency preparedness. They wanted a list of our severely immune compromised residents. Not even sure, I mean, all of our residents are at risk, but I just assumed anyone with active chemo radiation or like a new transplant, which we didn't have any of those. So they were here, they went out on the unit. I asked them about that and my concern, since we were limiting people in the building, and they said, no, for the state, we definitely have the right to go in and observe. But they did come in with masks. They exited our building up early afternoon.
1 o'clock.
And are still doing the survey from home, and are going to do an exit via a phone call probably
today. So they did call this morning, and she asked us again how we are monitoring and communicating to the staff all of the CDC information. So we went back through that again, and she was fine with it. And then she asked us how using one entrance to monitor all the employee temps and screening at the beginning of their shift, how we're maintaining the 6-foot distance. That was a big question for her. Yeah, and she also wanted to know how we were going to fit test, because that's been something we've been kind of struggling with anyway, because we don't have a fit test in the building, and we have no one certified in the building to do a fit test. So I told her that we had reached out to the Waterford Fire Department to see if they could do that for us. She was fine with that. And that was really about it this morning. I don't know if anybody has any questions. We certainly will let you know what they tell us this afternoon, and if there's anything that, you know, we can share with you so that other people can prepare for this.
Great. Well, we appreciate that, Maureen. Thank you. Are there any questions now of Maureen or her staff regarding this infection control survey?
I do not see any right now. I will wait a second. I still do have you unmuted, Maureen. I won't mute you until we move on, just so you know. I did get a question. Is the cardboard or is the card box fit test with a nebulizer with water and is the cardboard fit test with a nebulizer with water and appropriate for a fit test?
I think you have to have the fit test hood, which is pretty expensive. That's why we don't have it here. I think it runs like $300 or $400. They did not get into that specific with us of what type of device we were using to do the fit test.
Do you feel the surveyors leaning during this process as well?
I'm sorry, what, Blake?
Do you feel the surveyors are learning during this process as well?
We were their first survey. Yeah, I do believe they are learning. They weren't sure what to opt for. In fact, we said, do you want this? Do you want this? Do you want this? And they said, oh yeah, give us all of that. And so they took a lot more than what was on their list or what they actually asked for on the email. And that was the first survey in North Oakland County as well.
Okay. How many surveyors were present?
2, 1 nurse and 1 social worker.
Okay.
And they didn't go out and watch meals or anything, which I found interesting. So I thought if any time they were going to check to see, you know, infection control protocols in place, it would be during a meal, but they did not. But they checked the refrigerator temps.
All right. Well, I believe that takes care of the questions for that. So I am going to go ahead and mute you now, Maureen. Thank you very much for just talking and giving everybody that information as well.
Okay, Blake. So that is all that we have for today. As if that weren't enough, we will continue to post our Q&A and the recorded PowerPoint for this program, either at the end of today or early tomorrow. Again, we encourage everyone to communicate issues, questions, etc., to either our Safe and Calm address or directly to me or Laura Funch at our addresses identified there. We thank you for your attendance. We wish you well. We understand how difficult it is right now to continue during this emergency crisis, and we know that you all are on the front lines. So it is our pleasure and our job to serve you as best we can, and if there's any way that we can do that, please let us know further than what we're doing already. So again, have a good day, and thank you.